river chairpersons and the leaders of this POGS and all the members of this vibrant society of Foxy, a very new society, which last year I had personally gone and enjoyed and cherished the memories of this inaugural conference of POGS. And thank you very much, Dr. Kanjumuddin and Dr. Wahab and all the members of this POGS. And thanks, Jitendra, for reminding me morning and evening for last 7 days. And I know that you have emotionally blackmailed me, and that's why I'm here for that. And thank you again, all of you, for bringing almost around a galaxy of experts from the national faculty as well as international faculty. I think congratulations to the leaders like Kanjumuddin and Wahab. I think I was apprehending a crash landing of 160 passengers now yesterday, and today also it's absolutely flawless audio visual. Absolutely, I wish that 2 days conference will be a real success. It's not a absolutely a successful virtual conference in the COVID pandemic. Well, I've been given the topic. Can you see my slides? I think hysterectomy revisited. This is the thing which I'll quote from James Johnson in London Medical Chirurgical Review way back in 1825. About 150 years before, the statement was, we consider extirpation of the uterus not previously protruded or inverted one of the most cruel and unfeasible operation that ever was projected or executed by the head or hand of the man. We are very far from discouraging bold or untried operations, but there is a limit beyond which it may not be prudent to go. And what is the status now? It is after 150 years later, the hysterectomy is one of the commonest surgery operation for the gynecologist as well as for the surgeon. Now, hard facts. What are the types of hard facts in hysterectomy? Hysterectomy is the most common operation performed by gynecologist and surgeon. It is second most common major surgical procedure in females, next to cesarean section. If you go to statistics, about 6 lakhs hysterectomies are done per year in the United States. 30.4 per 10,000 women underwent hysterectomy in United Kingdom. And in USA, 1 of 3 is deprived of uterus by the age 60 years. When we come to the Indian statistics, we are lack in documentation. And as usual, we will be multiplying the global standards for that. Now, coming to the basic concept of surgical procedure. First, selecting the right patient for operation. Don't operate on any patient without an indication for that. Second, selecting the right operation for the patient. If there are 3 or 4 modalities of doing a hysterectomy, you must find out which is the right operation for that particular patient. Third is performing the operation correctly, and therefore the skill is important for that. The surgical techniques is important for that also. And if you adopt these 3, fourth you forget. Post-operative care is a big question mark. When somebody asks what is the most important post-operative care, I always say that a good piece of surgery is one of the most important post-operative care. Do it and forget it. And whatever complications are there in post-operative period, it is just stressable to the surgery, intra-operative part for that. And in hysterectomy, another important aspect is knowledge and understanding of physiology of reproductive organs, pathology and clinical manifestations of pelvic disease and dynamics of psychosocial and sexual development is absolutely necessary. You are not a craftsman. You are not surgery. And you must know everything about it. Now, coming to the status of hysterectomy, what are the key issues? These are the key issues. I must say one by one. Status of uterus to be removed first. Second, what is the status of surgeon? Third, what is the status of route of removal? And last, what is the status of changing trends and techniques for that? Every day we are changing innovations and the technical aspect with gadgets and all components, electronic, computerized, and everything has led us in a high-tech appreciation for the different routes. Now, what is the status of uterus to be removed? Many people believe that if the sole purpose of uterus is procreation and creation of diseases, there are some people who think that once procreation is over, why to wait for creation of diseases? You do a prophylactic hysterectomy for that. This is a gynecological terroristic approach for hysterectomy for that. But remember, the status of uterus to be removed. Nowadays, there are some unindicated surgery for hysterectomy. And many cases we find that there was a recent survey that there are 3 unindicated surgical intervention. The first surgical intervention is a cardiac intervention. Second surgical intervention is a joint replacement. But we, the gynecologists, stand in third. Hysterectomy is the third in the rank of unindicated hysterectomy. I think that should be condemned for that also. Way back, when I was going as an external 15 years back to the medical colleges in a postgraduate examination and asked what are the indications of hysterectomy. They were selling beautifully benign, malignant diseases of the uterus, cervix, and everything for that also. Now I go and ask, the surgery is very simple. Sir, presence of uterus is an indication of hysterectomy. Presence of pregnancy is an indication of cesarean section for that. So it's now very simple nowadays for that. And I think as a rational gynecologist, you must abstain from that. Second important is status of uterus to be removed. What are the indications? Now, uterine pathology. Benign and malignant is all right, uterine pathology. The commonest attributable uterine pathology is abnormal uterine bleeding, adenomyosis, or myomyuterus. These are benign and malignant. Of course, you know that there's no argument in case of removal, particularly in malignancy. But in benign, one question comes into the mind, rationality comes to the mind, that if abnormal uterine bleeding, the endometrium is defective. If the endometrium is defective, why to remove the myometrium? Why the innocent cervix is removed? Why the innocent uterus is removed for that? And that's why the concept of alternative methods of tackling the endometrium, starting from the Mirena to the hysteroscopic resection of the endometrium for that also, and balloon therapy for that. So these are medical management for that. So uterine pathology is one of the indications. Then cervical pathology, both benign and malignant. Adnexal pathology in cases of particularly the ovarian tumor, and particularly if in elderly age group, you remove the ovary, uterus along with the ovary for that also. Pelvic floor pathology. One question comes that pelvic floor pathology, the prolapse, uterus is most often sacrificed for that. But remember, there are some alternative. If the pelvic floor is defective, why the innocent uterus is being sacrificed for that also? That could be also a logical way of asking and tackling that. Obstetric pathology, obstetric hysterectomy in emergencies. Disease of adjacent organs. Say, for example, carcinoma rectum. The surgeon say that, yes, you do the hysterectomy so that I'll do a total pelvic clearance for that also. And of course, sterilization method. We don't accept sterilization. Hysterectomy is one of the methods of sterilization, as has been depicted by some authors in the United States of America. And last two, chronic pelvic pain. Undiagnosed chronic pelvic pain is really an indication which is being used, which should not be common indication for that, and one should absolutely abstain from that indication. Than just doing a hysterectomy. These are all indications, unindicated or unnecessary indications for hysterectomy for that. Now, coming to the preoperative evaluation. Preoperative evaluation, the genuinity of removal. One has to find which is the real indication for that. Pre-op investigations, it's a major surgery. What are the minimum pre-op investigations? I need not tell about the details of that. But what mainly pre-op assessment, what I mean to say, that if there are 3 or 4 methods or routes of removal of the uterus is there, you must be able to find out the pre-op assessment, which is very suitable for a particular method. Whether it is suitable for vaginal approach or is suitable for abdominal approach or for a laparoscopic approach, you must find out for that. And of course, preoperative counseling before any surgery, and most early before hysterectomy is necessary for that also. And preoperative surgical planning is important. I think this I want to again emphasize my students, that you are not a craftsman. Again, remember that you are a surgeon, you are not an operator. I think, believe me, surgery needs a dissection as well as decision. So both is there. It should not be restricted to only dissection for that also. Many people do not plan it. Surgical planning is important before doing the surgery for that also. And then and there you decide if there is something. I think the mental preparation is important. You assess that particular case, what difficulty in that particular case I would be encountering for that. If there is a previous history of surgery, a cesarean section, a myomectomy and all that, I find that the surgical, what is the real problem I can face it. You mentally be prepared for that, and therefore surgical planning is important for that. What is the status of surgeon? Gynecologist versus general surgeons. I'm from east to west and north to south. I'm finding if the wife is a gynecologist and husband is a surgeon, general surgeon, I think she brings patient and the husband operates and gynecologist says there is a difference, because general surgeons can operate. The decision is not there. He can have very good dissection, but decision as a pelvic organ, whether to remove the ovary, whether to keep the ovary, what are the methods in doing that, whether you do a laparotomy, whether you do a laparoscopic or doing a vaginal, that is better done by a gynecologist than by general surgeons. So adequate knowledge in surgical anatomy and more than adequate knowledge in pathophysiology is essential for that also. And after all, for a surgeon, it needs a surgical skill, commitment and expertise for that also. And in particularly in gadget-oriented surgery, I think the setup is important. You are not alone. The team is important. Even a gadget, particularly in endoscopy, in laparoscopic hysterectomy, you are not alone. The quality of surgery is all depends on the team and tool. It's not that the surgeon is very important. And after all, ethical, rational, and human factor has to be carried out by the surgeons for the status of surgeons. So now, if you give a man more than he can do, he will do it. If you only give him what he can do, he will do nothing. Or clipping hysterectomy. Now, status of route. There are definitely vaginal, abdominal, laparoscopy. These are the three main routes, and there are the debates which was going on for last so many decades, where when the minimal invasive surgery came forward, it all went against the abdominal, and debate versus abdominal versus minimal invasive surgery was there. Now that has ended. Every attempt has to diminish that. We know the disadvantage of abdominal hysterectomy, and all efforts has to be done. If it is feasible for a minimal invasive surgery like laparoscopic, or a feasible like non-invasive surgery like vaginal, keyhole surgery like laparoscopy, or a no-hole surgery like vaginal, then it's absolutely warranted. And worldwide, there is a really decline in the incidence of abdominal hysterectomy for that. And future, I don't know what is the next future generations will go, as because I remember my anesthesia professor was telling, we have observed you people operating, you removing the uterus by abdominally, removing the uterus by vaginally, removing the uterus by laparoscopy. I'm waiting for the time when you will remove the uterus by the nose, by the mouth, by the rectum and all that for that. I replied that the time is there. I'm dreaming of one procedure where you enchant a mantra and the uterus is out, and so that no cutting, no dissection, no coagulation is necessary for that also. Now, when your only tool is a hammer, every problem will look like a nail. So don't have a dogma in science. Everything, if you are a laparoscopic surgeon, you say that only laparoscopy is the only route. If you are a stench vaginal surgeon, you say that only vaginal is the route, and you do not. And if you are a conventional old surgeon like abdominal, I find that abdominal is the only rule for that. I think dogma, the science doesn't believe in dogma for that. Each individual has a benefit or merits and demerits for that also. As for example, abdominal hysterectomy, more than 80% is performed in UK and USA. Technically easier, access and visualization of abdomen and pelvis is much better, a very enlarged uterus, adnexal pathology, previous pelvic surgery, pelvic pain. So these are indications of abdominal hysterectomy. I think this is more of a convention and practice. As you devote more on the technological aspect, I think the endoscopic approach or vaginal approach, the declining incidence of abdominal hysterectomy is there for that. But we cannot say in the present context that there is no place for abdominal hysterectomy. Still, there is a place for abdominal hysterectomy in certain special situations, because the safety of the patient is primary thing. It's not the mood of the surgeon, it is the need of the patient which is important for that also. You have to decide in such cases when there is a repeated surgery and you know that there is an endometriosis, lots, 3-4 times operation has been done, you can't see anything for that also. And there is a definitely place for abdominal hysterectomy for that also. So I don't say that abdominal hysterectomy has gone to graveyard. Still there is a place, but simultaneously I can say that the incidence of abdominal hysterectomy has been gradually declining as we go for minimal invasive or non-invasive surgery. Vaginal hysterectomy, what are the advantages? It's the oldest recorded in history. familiar with gynecology. It's the signature of the gynecologist. If the gynecologist doesn't know vaginal hysterectomy, he is not fit to be designated as a gynecologist for that also. And it's a signature. Reduced mortality and morbidity, obese, elderly, and high-risk subjects, rapid recovery, shorter hospital stay, minimal blood loss, minimal instruments, minimal complications. And that's why I always say vaginal hysterectomy is a non-invasive surgery. Vaginal hysterectomy is a no-hole surgery. And what are the disadvantages? Disadvantage of vaginal hysterectomy. No glamour is there. No money is there. Surgery of minutes rather than hours. You finish the surgery within 15 minutes rather than 2 hours in a case of TLH. Need for good anesthesia and light and assistant. Difficult to learn. Challenging situations. Need for meticulous surgical skill and non-compliance. Don't think that is a blind procedure. There are a lot of advantages. Now the different vessel sealers are there, exposures are there, and good lighting system is there. It's never a blind procedure for that. Now, laparoscopic hysterectomy. Scope of laparoscopic hysterectomy has been broadened for the last 2 decades. Definition, classification starting from Jones and Jones and all that. Merits over abdominal hysterectomy and vaginal hysterectomy is there. Types, technical aspects, advantages and disadvantages. I think advantage, it's a minimal invasive surgery. Everybody knows that is the case. But disadvantage is also there. More of urological complications. High skill is required. Lot of learning curve is more prolonged for that. And particularly, it's a gadget-oriented surgery. Understanding the team, tool, and the cost factor is also important for that. And of course, complications. And future, I don't know what will be the status of laparoscopic hysterectomy. Because nowadays, people are crazed for doing a TLH. Whatever may be the size of the uterus, I condemn that. Each individual case has to be judged whether laparoscopy has to be done for that. Even I say that, yes, whenever in the vaginal surgeons, they say that all cases we can do it with that. That's a dogma. I don't believe in that also. So mainly, if there is a clear indication of laparoscopic hysterectomy, if there is a persistent pain, if there is a adhesions and all that, then you can do it. But of course, majority can be tackled by vaginal route. There is no doubt about it. More than 90% of the cases can be tackled by vaginal route, safety for that. We have made surgery safe for our patients. Let's make our patients safe for the surgery. That should be the safety first for that. Another key issues, whether subtotal versus total, laparoscopy, LAVH versus TLH. People are now crazed for TLH, the youngsters. I caution them. Indications should be individualized. The patient need is more important. Your mood is not important. If I know that this is a mood of the gynecologist is more important, I think this is irrational and unscientific. Ovarian conservation versus removal. It is again an issue for that. In only case now we have, age is not a bar for ovarian conservation or removal. Age is absolutely an arbitrary figure for that. So ovarian conservation, when there is a strong family history of malignancy, I think these are the cases where you remove it. BRCA positive and strong family history, extensive adhesions, peri-ovarian adhesions, or a ovarian disease. I think these are the cases you sacrifice. Otherwise, try to conjure the ovary. Clamp versus clampless, suture versus sutureless. I think the technology has given us ample opportunity to find out, yes, vessel sealing devices, both in vaginal, abdominal, as well as laparoscopic procedure. Sutureless has many, many advantages for that also, apart from the timing, apart from the safety, apart from the various advantages of difficult, complex cases, making it simple. This is important. Staged versus joint procedure. If there are 2 pathologies at the same time, a gallbladder as well as the uterine pathology, you can do it minimal invasive surgery, both in the case, and completion versus conversion. You procedure, any procedure you start, there is no complacency in that, no dogma in that. You can convert it at any procedures and convert it for the benefit of the patient. You can convert it into different procedures for that. So man learns as he lives, and experience is the greatest teacher in the world. And this needs a lot of skill and learning, and that is important. No dogma, everything you decide as an individual basis. But main thing, in the era of minimal invasive surgery or non-invasive surgery, we are more inclined for the minimal invasive surgery or non-invasive. Message I must give you, it is important for the surgeon to select the operation that is best for the patient and not the one that is best for the surgeon. That is the primary thing. Whether this surgery is best for the patient or best for me, if the best for the All uteri that can be removed vaginally can be removed by the abdominal route or by laparoscopic hysterectomy. But the reverse is not true. There is a global reduction in the incidence of abdominal hysterectomy of a concomitant increase in lap hysterectomy and vaginal hysterectomy. And only when vaginal hysterectomy is contraindicated, lap hysterectomy should be considered. This is absolutely Hari Rich statement. Hari Rich, one who performed the laparoscopic hysterectomy, he told that when vaginal hysterectomy is feasible, laparoscopic hysterectomy has to be condemned for that. So only when vaginal hysterectomy is contraindicated, lap hysterectomy should be considered. And when lap hysterectomy is not possible, then abdominal hysterectomy has to be considered for that. So decision as to the route is based on patient choice, expertise of the surgeon, and setup available. Adequate training is an essential component for the optimum result. Whatever procedure you do it, a good surgical transfer training is important for that also. And skill transfer by the teachers is absolutely important for the new generations for that. I remind Francis Bacon's statement, need not to contradict and confute, not to believe and take it for granted, not to find and discourse, but to weigh and consider. That is the principles of rationality. That is the principles of science for that. Thank you, all my chairpersons. Kunjumuddin, you have given me opportunity to see the face and hear sounds from my friends like Rishikesh, Ashwath, Narendra, Damodar, and Kunjumuddin, our Gopinath sir, and many, many more for that. You have given a lot of ample opportunity for me in this virtual conference. I think I'm physically very strong, but digitally the weakest ever possible in comparison to Narendra, Ashwath, and other people. Thank you very much all for giving me this opportunity.